And we once again have a full agenda, so I will go ahead and have Becky take the roll, please.
Senator Rocky Adams. Senator Chambers Armstrong.
Here.
Senator Byrd.
Present.
Senator Carroll. Senator Douglas.
Present.
Senator Elkins.
Present.
Senator Funky Fromeyer.
Present.
Senator Nemes.
Present.
Senator Tishner. Senator Wise. Representative Bentley. Representative Bratcher.
Present.
Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Dotson. Representative Duvall.
Here.
Representative Fraser Gordon. Representative Justice. Representative Neighbors.
Here.
Representative Palumbo.
Here.
Representative Raymer. Representative Riley.
Here.
Representative Rorks.
Here.
Representative Sharp.
Present.
Representative Weber. Representative Wilner.
Here.
Representative Witten.
Here.
Co-Chair Meredith.
Present.
Chairwoman Mosier.
I'm here. Okay, we have a quorum and are duly constituted to do business. And the first order of business is approval of the minutes.
Motion to approve.
Thank you.
Second.
We have a motion and a second. All in favor of approving the minutes, please indicate by saying aye.
Aye.
Any opposed? Okay, thank you. All right, well, the first, we do have, good. Whitney Westerfield is online to weigh in on the first agenda item, and I will go down to the table and hand over the microphone to my co-chair, Senator Meredith.
Thank you, Madam Chair. Senator Westerfield, I'm glad to have you with us this afternoon, and you're familiar with the formality here. If you would, please identify yourself for the record.
Whitney Westerfield, Senator for the 3rd Senate District. Thank you, Chairman.
Thank you. And Madam Chair, if you would do the same.
Yes, I am Representative Kim Mosier. I represent the 64th District, and I'm very happy to be with you today.
We're discussing an act relating to mental health, so please proceed. Excuse me, maternal health. Please proceed.
Thank you. I am very happy to be with you today to discuss a bill draft that I have worked on throughout the summer with a very nice bipartisan, bicameral, informal work group discussing maternal health. And we've done quite a lot of work with the Cabinet Deputy Commissioner or Assistant Commissioner, Dr. Connie White, and her team at DPH, and also the Department of Insurance. And we've really tried to pull all of the stakeholders together to take a deep dive and hard look at what is affecting maternal mortality in Kentucky. We know that new Kentucky mothers die at a higher rate in Kentucky than 48 other states. This brings Kentucky in with the second highest maternal mortality rate in the country, and this is according to the CDC. According to the World Health Organization, the U.S. has one of the highest rates of maternal deaths among developed countries at 23.8 deaths per 100,000 women. For Black women, the maternal mortality rate more than doubles. Black women, according to the CDC, die at a rate of 55.3 per 100,000 births in the U.S. Shortly after giving birth. Experts say that nearly all maternal deaths in the U.S. are preventable. The advocacy group Every Mother Counts lists the leading causes of maternal death in the U.S. as lack of access to health care, including a shortage of caregivers, a lack of insurance, inadequate postpartum support, and socioeconomic disparities in the stress of racism and discrimination. Many patients are dealing with additional health conditions which contribute to our high maternal mortality in Kentucky, such as obesity, diabetes, heart disease, even poor dental health, in addition to substance use disorders, which are exacerbated by the lack of access to adequate health care. The bill draft addresses each of these issues. I had the pleasure, again, of working with so many of my colleagues, and I thank you for participating in this and really giving honest feedback about exactly what we need to work on and how we can do this without getting too big, but really targeting exactly what we need to work on. And, of course, taking it from there if in later sessions we discover that we didn't do enough or we did too much, we can adjust it. But this bill draft is, and I just want to say I'm a little disappointed that the Cabinet's not here with me today because they were so helpful in working on this draft. And I'm a little confused about why they couldn't be here. I heard that part of the reason was because this bill was not in the governor's budget yet, but that actually never happens in the interim. So I'm not exactly sure. Obviously, this is a very important issue for all of us, and I think that we're all very concerned about maternal mortality and certainly how it affects the babies who are born to all of our Kentucky moms. And I can say definitively that maternal health is, and saving mothers and babies is a priority, especially for our caucus. And we want to make sure that we are supporting moms and babies. And that's really what this seeks to do. It's my hope that we are in alignment when it comes to the budget, that we're not the only ones who are putting this in our budget. And I think, I don't know that was really the message I was hearing. I'm just a little confused. So I, though, am happy to be here with you today. I want to talk a little bit about our proposal and how we're looking to support mothers through prenatal care, through the whole pregnancy, through delivery, and through postpartum. The initiatives that we are addressing here, which are of high concern, include the high rate of substance use disorders, which is the number one reason that women die in the year following a birth in Kentucky at a rate of 53%, and another 14% where drugs are suspected in contributing to a new mother's death. It also includes a lack of insurance coverage and access to prenatal care. Mental health treatment, education, and a referral to services including treatment, support, and follow-up care are all issues that we're trying to really support here in this language. So the first thing that we are doing, and I believe everyone has access to this bill draft, is BR 442. It's on the website, and I'm just going to, kind of go through section by section, not to belabor any points, but I think it's important to really know what we're trying to do. The first section will establish the Kentucky Maternal Psychiatric Access Program, also known as the Kentucky Lifeline for Moms, and it establishes the duties, and it's all set out through the Department of Public Health. Section 2 establishes or strengthens a collaborative panel that was established last year in Senate Bill 135. It just kind of really focuses the effort on maternal health. It's going to be renamed the Kentucky Maternal and Infant Health Collaborative. The membership is made more detailed in this bill, and the collaborative shall now annually review the operations of the new Kentucky Maternal Psychiatric Access. So we want to make sure that we have appropriate access or oversight of the program. I will just also mention that this is a national program that DPH had already started working on, and they applied for a HRSA grant, and Kentucky was awarded $750,000 to begin to implement this program. We want to codify this and make sure that this is available on an ongoing basis for moms. Let's see, Section 3 talks about the Health Access Nurturing Development Services, and that is the HANDS program that you have probably heard about. It's available to any mom, really, who applies for it, but historically it's been focused on our at-risk population, but like I said, any mom can apply for prenatal services, and this is an ongoing program through the child's third birthday. So it's a really great program that provides a lot of referral assessment of a family's current situation and referral to any programs that they might need. But what we're doing here is expanding the program, the HANDS program, and including lactation counseling, lactation consultation, and breastfeeding information. We will also be requiring that the HANDS program provide information on safe sleep for babies, and this was a recommendation out of the Child Fatality and Near Fatality Review panel that we have, and it looks at all of the reasons why infants why they die in the first year of birth, and safe sleep kept coming up as a reason. And so we felt like this was a very appropriate place to enhance education about that. It also codifies new regulatory language that specifies that participants in the HANDS program shall participate in the home visitation program so that we ensure that new moms and their families are getting a hands-on approach to the care that they need. It also allows for telehealth services, and so that's kind of tying this to telehealth. We know that in some rural areas and areas of our state where we don't have the providers, this is a very important piece of what we can do. The big piece of this, in case those aren't big enough, because I think they're very important, but we discovered that in Kentucky, we need a special enrollment period for health insurance. And currently, a special enrollment period in Kentucky is provided for marriage, birth, adoption, or placement for adoption, but pregnancy is not a qualifying life event for insurance coverage. And so when we're thinking about how we best support mothers who may be in a crisis pregnancy or are in a high-risk situation, any reason why they don't have insurance coverage, and we know that it makes such a difference in their life, that we want to make sure that we add a special enrollment period. So that would add a special 30-day special enrollment period for women who find out they're pregnant. This is, verified by a physician or their health care provider. And so we're working through the details of all of this information, really sections 4 through, I think it's probably 9, add a lot of conforming language and specify exactly which insurance providers are, and it's in this language right now, it's everyone, even down to the coverage for students at a university who we know If they get pregnant, they drop out of college. We really want to find a way to help support these moms so that they can keep these pregnancies and have a healthy baby. So that's really what the rest of those sections about insurance coverage go over. Let's see. So I talked about the psychiatric access. We know that mothers in a crisis situation especially really need those mental health supports. So just a little bit of detail on that maternal access or psychiatric access program. It's not a hotline. It will establish a hotline, but it's not a hotline for patients per se. It's a hotline for OBGYNs to contact a psychiatrist for the best treatment for their patient. And this is something that's working in other states. We feel like this is a really important way to extend psychiatric or mental health treatment specifically for the maternal health and the mothers who will need this. And it's specific to this population. I also want to mention a couple of years ago in 2022, we passed some legislation that extended Medicaid for a full 12 months following the birth of an infant. And this is kind of an aside, but this language really picks up where that left off and just enhances care. But I've been talking to a lot of stakeholders, and that single initiative that we put into place, we extended Medicaid, is allowing for a strong continuum of care for at-risk moms, especially those who have a substance use disorder or a mental health issue. And it's really allowing them to continue their care. Before this, they only had coverage for 6 weeks of care following the birth of their child, and so they really weren't able to really work on issues that might have been identified, hypertension or diabetes and gestational diabetes, all of the things that we know affect moms and their pregnancies and certainly babies. I just want to kind of say we're having success because of that one initiative. So that was exciting for me to really hear. The last parts of this deal a little bit more with lactation coverage, and we're trying to work out with licensed IBCLCs, they're called. They're an international board certification for lactation consultants. We don't have a certification or a licensure in Kentucky. We're not seeking to do that here necessarily, but we are looking at ways to ensure that if someone is licensed and they are hired by a hospital or a healthcare provider, that they will get paid for their services. And so it's all part of tying hands and that referral to services. If a hands worker identifies a mom who needs lactation services, we don't want to say, well, here's information, but you don't actually have coverage. So we're just trying to complete the package on that. And then the last thing that this does is insert some study language for the Cabinet for Health and Family Services to study doula certification programs. We don't have a certification in Kentucky. The jury is kind of out on whether or not doulas want a certification or not, but we want to look at that and try to understand the services that they provide or could provide, and whether or not we need a certification or a licensure. So that is basically what this bill does. We are very excited about putting this together. We're kind of affectionately calling this our Momnibus bill. And I just think it's a great way to really support moms and babies and address the high maternal mortality rate that we know we have. So I am happy to answer any questions, and just wanted to make sure that you all knew what we were working on, and there are probably some changes coming, but...
Thank you, Madam Chair, and
Yes.
excellent presentation. Got a couple of questions for you. Before I get to those, Senator Westerfield had to board a plane, was not available,
Okay.
but he wanted to tell you that.
I'm still here
Good,
for the
thank
moment.
you. All right. Well, please
Thank
proceed,
you,
and
Senator. Yes,
when you
please.
leave, we'll fill the gap for you. So please.
Well, I appreciate that, Mr. Chairman and Madam Chairman. I can't beat what you just heard from Chair Moser. And I'm thankful that she included me in many of her maternal health, her mommy bus work group meetings. I'll just say this. Kentucky needs to invest in moms and children before they're born, when they're in the womb, after they're born, and as they're starting to grow in their early childhood development. And we needed to be doing that well before the Dobbs opinion, but certainly post-Dobbs, this is the place where Kentucky needs to invest more than we are today. And we've done some things that are good, but we need to do a whole lot more. And it started, what prompted this for me was the conversations I had with some of the post-abortive women at the crisis pregnancy center in my area. I've spoken to a handful, and my wife has spoken to many, many more than that, as she was the director there. And the vast majority of the women who came in there abortion minded, thinking about getting an abortion, some of whom went on to get an abortion. They weren't in there for a medical reason. They were in there because of some pressure they were feeling in their home. The boyfriend or the father of the child was pressuring them to get an abortion. Their parent, their preacher, God forbid, their boss, their coach, or someone else in their family, or they were worried about some of those people pressuring them or guilting them or shaming them into getting an abortion because of some unplanned pregnancy. People talked about, the women I've spoken to talked about the cost of housing and the cost of transportation and the cost of education. Government can't fix all of those things. Government can't fix a preacher that's shaming someone in his church or her church. But government can make school cheaper. It can make housing cheaper and transportation cheaper. It can do a lot of the good things that it ought to do. And that's what we ought to invest in. Those are the things that we should be able to do. I've got Bill BR8, and I've shared a link to a blog post that explains everything I just said, along with a copy of the bill and a summary of the bill, section by section, in the chat there on the Zoom, and you all are free to distribute that to committee members. It's just a starting point. There's a lot of overlap between my bill and what you heard Chair Moser describing hers. And I'm so glad that there are a lot of people working on this. And as Chair Moser said, rightly said, and she can be commended for her leadership, working on a bipartisan, bicameral group. There's a lot of interest in both chambers, in both majority and minority caucuses, and we should take advantage of that interest. This is a place where we need to invest a lot more than we are. And there's a lot of mamas and babies, born and unborn, who can
Thank you, Senator. You kind of cut off abruptly. Does that conclude your remarks?
Yes, sir, it does, from the Jetway in Nashville.
I understand. Thank you very much. Appreciate you being available to us today. And for the committee's information, the Zoom chat in summary he's referring to is available on WhitneyWesterfield.com, and we'll get that information to you, but we appreciate that. And with that, we'll open this for questions. But first, I'd like to ask, again, thank you for presenting this bill. I certainly agree that this is a nonpartisan effort. One of the few things that we all agree on has to be addressed. And I think the attention we've given it to the last 2 or 3 years has certainly been warranted. I'm very proud of what we've been able to accomplish so far, but we know the work is far from being concluded. You mentioned that lack of insurance is one of the issues related to maternal mortality. Do you have any historical data as to what it looks like in 2012 compared to now, since the Affordable Care Act, since that was supposed to address this? Do we have any information relative to that?
Yes, I can say that largely Medicaid covers new moms, and so that's the ACA. We have better coverage through Medicaid than we do for just about any other insurance coverage right now for pregnancy. The reason that I'm including it here is to codify that, because that was done through regulations, and we just want to make sure that it doesn't go away regardless of the administration.
I appreciate that. And you know I'm going to ask this question, but do you have any data specific to urban versus rural as to how this is impacted?
As far as the maternal mortality
Yes.
rates? Oh,
Yes.
yeah. I mean, the Kentucky Perinatal Quality and the Maternal Mortality Review Panel have all of that information, and we can share that as we get into the specifics. Obviously, only the moms who need this insurance coverage would access it. So we don't anticipate that this is going to be a large number. And so regardless of whether you're rural or you're urban, if you need insurance, you should have access to that. So I think that addresses maybe the question that you were asking about. I mean, we can get those numbers, and it certainly matters when we're looking at other initiatives, but in terms of insurance coverage, I think broadly speaking, if you're covered by Medicaid, if you're eligible for Medicaid, you'll have that coverage. If you're somewhere in the gap, you may not be eligible, and this would be an avenue for you. The women who are pregnant and accessing this coverage are expected, of course, to pay premiums, and we've worked out all of that language in the bill.
Well, it was kind of a leading question, and it wasn't intended to put you on the spot, but what I'm trying to get a link to is that having insurance coverage is not commensurate with having access to care. I think it's still more pronounced in rural Kentucky, and you would expect me to say that. It's a frequent comment that I make. But with that, we have Senator Funky Fromeyer. You have a question, comment?
Yes, both. Thank you, Representative Mosier. I'm excited to be on the Momnibus myself. I think that's wonderful. And this is very much of a culture of life bill that I know you're working on. With the work that I'm doing on freestanding birthing centers, I see that as a tie-in, because you mentioned two key things: a lack of access and the shortage of caregivers. And we're trying to recognize that there are midwives that could be very fruitful in that proactive, or that getting ahead of the illnesses that people are battling, and how to be preventative and proactive. In the bill, you mentioned home visitation programs. Who are you tying that to from a provider perspective? Who's offering that care?
Right. So the thank you for that question, and I'll get to the freestanding birthing centers and the midwives comments in a second. But the hands workers are I don't think that they are nurses, but they are healthcare workers. They can be community health workers, social workers. I believe I'm correct. I will have to dig down on that a little bit more. But if needed, I believe part of this is a nurse can be afforded an individual. I mean, certainly the person who, the hands worker or the hands program worker, makes a referral to a higher level of care if they need that. We decided to keep this bill really focused on the issues that I've talked about today, because I know that there are some separate discussions about freestanding birthing centers and that access to care and the process for applying for those freestanding birthing centers. So that's separate, and we decided not to put too much in this bill. The same goes for Medicaid coverage for midwives. There's a separate bill dealing with that as well. Mm-hmm.
We have, for the legislators who have requested an opportunity to ask a question or make a comment. So if you folks don't mind, I'm going to cut it off because we still have a lot of agenda to do here. And we will certainly have more discussion about this when we get back in session. But with that, Senator Chambers Armstrong.
Thank you, Mr. Chair. And I wanted to publicly add my thanks to Chair Mosier for her leadership on this. And also emphasize that this is a very Kentucky solution to what the problem of maternal health looks like in Kentucky, which I think is really important because this process started with what do we know about the data in our communities, in our state? What do the experts say are the best solutions for those problems? And how can we craft something that makes sense in our current policy landscape? And I know that is really hard to do. And you and many other legislators have spent dozens of hours on that process. And so thank you. I think that this is a really wonderful policy solution. I just wanted a quick question. One of the conversations I thought was really important was around the special enrollment period and how moving that upstream, that ability to enroll in insurance upstream as opposed to waiting for a birth is really important for the moral reasons, for the health reasons, but can also be really cost effective. And so I'm wondering if you could spend some time talking about that.
Yeah, absolutely. I know, and many folks here know that there's no shortage of healthcare woes in Kentucky. We certainly have a lot of situations that exacerbate the issue of maternal mortality or maternal deaths, and those would be all of the all of the issues plus others that I mentioned before. So, starting with obesity, diabetes, heart disease. And so, I mean, if we, for example, can identify a mother during her prenatal period with hypertension or gestational diabetes, we are going to have a much more successful birth and outcome for the baby. And you're right, the return on investment is, I think, it's ridiculous not to have this coverage, and really allow moms who, and we're going to have to do some education around this, educating moms that this is available now and the importance of having prenatal care. So there are many reasons for prenatal care. It's an opportunity for healthcare providers to identify a substance use disorder early and prevent neonatal abstinence syndrome. So, all of a stint in the neonatal intensive care unit, and I worked there for 18 years. It's expensive. I mean, you can probably, if you have an NAS baby, if you spend 2-3 weeks in the NICU, you're going to have a $500,000 bill. And so that clearly is offset in having insurance coverage, and it's just better for everyone involved.
Thank you for your leadership, and thank you, Mr. Chair.
Thank you. Representative Palumbo.
Thank you, Mr. Chairman. I just want to say thank you.
You're welcome.
Appreciate your hard work. Thank you, Mr. Chairman.
Thank you. Appreciate that. Representative Burke.
Thank you, Mr. Chair. I also want to thank you for your leadership, Representative Mosher. Sure. It's great to see that these bills have become the momnibus. I want to tip my hat to my colleague, Representative Stalker, who proposed in the last session that we do the special enrollment period. She worked really hard on that bill, and so I'm very grateful that you've taken that now to make it something that the whole can adopt, because our moms in Kentucky really deserve this. I also want to tip my hat to Representative Palumbo because she was one of the sponsors of the HANDS maternal mental health bills that we passed last session that's now being built upon. So there's been a lot of great work in this direction, and the momentum that you're putting behind it, Representative Mosher, is something that we need and we're grateful for, and is definitely good for moms across Kentucky. My question is, are we able to add to this bill things like the pink tax? Kentucky women are paying for things more out of their pockets than similarly created products such as female healthcare products. is that something that we could conceivably add to this bill so that it is not harder to be a mom than it already is? Thank you.
Well, thank you. And first of all, I want to thank you for talking about our colleagues who have done so much work on this. And I would be remiss in not thanking Representative Stalker for her work on the insurance piece. I think you're here. Thank you. And certainly Representative Palumbo. But we've been working kind of in a piecemeal way on chipping away at this issue, and this is just trying to be a more comprehensive look at the whole situation. And so, it was hard to cut some of these things out because we had discussions about feminine hygiene and the reasons why we should have a tax credit. But knowing that tax credits are very difficult, I didn't want to slow this bill down because I think that insurance coverage and the psychiatric access is so important that I really want to focus on the issues that I think we can pass. And, it all becomes a really heavy lift. And, you were gracious enough to come to some of these meetings, and we had these conversations about all of the different, we looked at, all sorts of data. We looked at all of the different ways that we can support moms. It's a long, long list. But we need to be very focused on, I think, what our priorities are right now. And it's not to say that might come up in a separate bill. I think actually it will. I'm hearing that it will. So I'm for it, but I didn't want it to slow down this process.
I understand, and thank you so much.
Of course.
This is certainly an important topic, and I'm sure we could spend numerous meetings on this, but I'm going to have to give a hard stop to this. I've got a question from Representative Dotson, and the last remark I'll hold for Senator Douglas. So.
Thank you, Chairman Meredith, and thank you, Representative Mosier. And this is one dad that wants to get on the omnibus bill. And
Awesome.
the reason, the question I have, and it's very personal to me because my eldest daughter gave birth to her second child, and she went into deep postpartum depression. Mm-hmm. And you referenced the mental health aspect. Right. Does this deal with postpartum depression? Because I know how bad it got for her. She even became thoughts of suicide.
I know.
And so it hits very personal to me. Mm-hmm. And I thank you all so much. I want to thank the task force for taking on this bill. So again, it becomes very personal, and I see all the aspects that you mentioned today, but one in particular. Could you explain on that mental health side with the postpartum part?
I would be happy to, and I certainly hope that your daughter is doing well and that she got the help that she needed, because that's really the point of this whole bill. We have the HANDS program, which is the visiting nurses or visiting healthcare program that would be able to identify someone who is having issues with postpartum depression. The other pieces of this is when your daughter or someone who has given birth returns to their OBGYN, they would have direct access to psychiatric care because of the Lifeline for Moms program that we're putting in place here. Not all OBGYNs get the training in mental health care or psychiatry to be able to deal with these really complex issues and referral to treatment. So that's what the Kentucky Psychiatric Access Program would be.
Final word on this topic is Senator Douglas.
Thank you, Mr. Chairman. If I may, and I'll try to make this quick. Earlier in this interim, we had some testimony from some experts who suggested that maternal mortality, 93% of the time, involves substance use disorder. Representative Mosier, I really want to thank you for looking at this slice of the maternal mortality picture. This is not obviously. I just want to make sure that we all understand that we're talking about a slice of the maternity mortality picture. in the United States in 2020, 40% of the live birth, 40% of the births were covered by Medicaid. In Kentucky, 48% of births were covered by Medicaid. In 2022, 45% of the births in Kentucky were covered by Medicaid, and still 41% in the United States are covered by Medicaid. So anyone who wants to argue that we are not putting money into this area needs to go back and look at some of the data. I want to make sure that we're looking at this in a pragmatic way, an objective way, and not just an emotional way. And we need to really keep track of some of these numbers and not just go down certain roads. I often ask myself as a physician, what discussions are we having about the accountability when we look at our overall Medicaid budget, about the multiple pregnancies that are occurring, and the fact that we continue to have a large number of births, seemingly without a lot of long-term thought about who's going to pay for these kids. So this is not, what we're talking about this morning is just a slice, but I just want us as a legislature, because this is going to come up, to keep our eyes also on the big picture in the Medicaid area, because there is no free money. And unfortunately, folks, we've been elected to make hard decisions, whether you like them or not. And some of those decisions people are going to be happy with, and some of those decisions people aren't going to be happy with. And if you're not really willing to make those hard decisions when it comes to some of these things, you probably shouldn't run again. So just keep in mind that we are looking at a big picture. And I really want to thank Representative Mosier for saying, okay, we need to kind of get this magnifier and look where we need to be putting some of our priority money. I want to thank you very much, Representative Mosier.
Thank you. And Mr. Chair, if I could just respond quickly. I agree that we have a large and a growing number of individuals who are accessing Medicaid. I say this a lot because I work primarily on healthcare issues. But if we can work on a healthier Kentucky and healthier Kentucky citizen, we are going to positively impact our workforce, our criminal justice system, our healthcare system, our educational system, and ultimately our economy. And we will have less people accessing Medicaid. So obviously this is our goal. We are looking at this issue because this is a crisis and we need to get our hands around it. But I think you're right. I mean, we need to ultimately look at how to make Kentucky a healthier place. And I think we're doing that. We're looking at access to care. We added community health workers last year to address that very thing. Individuals have access to coverage, but they're not necessarily accessing health care. Why? And so we need to really continue to hone in on that. And I think, the more we do this, the more the return on investment will positively impact individuals and families, but our society and our state budget. So, thanks.
Certainly this is a multifactoid problem. And I think the common denominator for most of the issues that we get to deal with is the poverty that we see in this state. And we talk about it a lot. We throw a lot of money at it, but I don't know if we've ever had a real definitive plan to address poverty in Kentucky. And would hope that we could tackle that with the same passion and commitment that we did with the COVID situation. And there's no reason why we shouldn't. And that would resolve a lot of our problems. But I thank you for your bill, Co-Chair Mosier. And look forward when we go into session to have further discussion regarding this. So thank you for your bill. Thank you for your time. Thank you for your commitment to this. With that, I'll let you assume the chair.
Okay, thank you very much, Mr. Co-Chair, and you did a fabulous job, as always. All right. Next on our agenda, we have several folks online and one person in person. I think Julia Rea, thank you so much for being here with us. And then online we have, Tom, I'm going to butcher your last name, Tom Pietschewitz, Jenny Mullins, and Megan Moore. And they are here to give us an update on a program called Multisystemic therapy. And this is I think somewhere in this we will get some background, but this is a pilot that we have that is currently operating in our state. And I just wanted to kind of see where we are on the pilot and talk about what the program is and how it's operating. So thank you, welcome, and I appreciate everyone being here with us today. Just identify yourselves for the record and then proceed. I'm not sure who wants to go first. Tom, are you up?
Sure. Thank you very much, Madam Co-Chair. My name is Tom Pietschewitz of MST Services, and we've got representatives from our partner providers in Kentucky that are ready to brief the Interim Joint Committee right now, about 5 minutes each, and hopefully we'll have some time for questions and answers if that works. My question is just operationally, should I share my screen now to show the presentation, or can the staff put the presentation up and then we can go through the slides?
I think you need to do that.
Okay, great.
Tom, would you like to provide a brief overview of multisystemic therapy to kick us off?
Sure, I'd be happy to do that. Thank you very much. For the committee, multisystemic therapy, it's an evidence-based program that empowers at-risk youth, and we define that as youth that are at risk of being placed out of the home, and their families to function responsibly over the long term. MST reduces delinquent and antisocial behavior, child maltreatment, and substance use by addressing the core causes of behavior, and views the client as a network of systems, including the family, peers, school, and community. The MST treatment, multisystemic therapy, is specifically tailored to the strengths and needs of each individual youth and family, and want to emphasize with family members playing an integral role in helping plan and implement interventions. As far as the delivery of MST, very quickly, MST Services, which we are headquartered in Atlanta, Georgia, we are the purveyor of MST services. So we provide licensing, program support, and ongoing quality insurance to ensure fidelity of the program. But MST is delivered with our partner agencies, and that's who's going to brief the group today primarily. So hopefully my slide is up right now, and I think it is.
There we go.
And so just to let you know, for the group who's on today, you can probably see my presenter slide. Presenting from CHNK, Chunky Behavioral Health, will be Julie Ray, who's the Chief Strategy Officer. And then from Home of the Innocents will be Jenny Mullins. And then from KVC will be Megan Moore. We do have MST services staff that I want to just address that will be here for the Q&A section. So if Julie, if you are available.
Sure. Yes, thank you, Tom. Good afternoon. Julie Raya with CHNK Behavioral Health. And I'd like to just thank Tom and the team for allowing us to be here. We are privileged to be part of this pilot program in Kentucky in conjunction with Home of the Innocents and KVC, in collaboration with the Department of Community-Based Services and the Department of Medicaid. CHNK joined the pilot in the fall of 21, and since then we've implemented with one team. We are serving the 12 counties of the Northern Bluegrass region, though primarily Boone, Campbell, Kenton, and Grant at this time. We receive referrals from DCBS only, the Department of Community-Based Services, and we have a team of just 2 therapists and 1 supervisor. Since starting the pilot, we have served 69 unique clients. We have discharged 58 of those 58 clients. 89% of youth were still living in the home at close of services. 91% were in school and or working, and 96% of those youth had no new arrests. I believe that those statistics demonstrate the strengths of the program, the model, and the team at CHNK. I will say there are some challenges, primarily recruiting and retaining the therapists to provide these services. As you have probably heard many times, there's a lack of therapists in the field. It's even harder to find those who want to do in-home work. MST works with a challenging population, older adolescents who are often have criminal involvement already and are at risk for criminal involvement, and so there are concerns in doing this work. The strength of the program model, though, it is very structured with a lot of guidance and support from the MST team, including a supervisor, a consultant, and a coach. So we get all the support we need. We just need to grow our clinical capacity. There's also a requirement in the program, a stipulation that the team be able to respond within 90 minutes to a crisis. That makes it difficult to serve such a large 12-county region. We can't get from Kenton County to Scott County in 90 minutes. So we know we need a second team. We could probably use a third team. And again, if we could just grow the clinical capacity, we look forward to doing that.
Jenny Mullins with Home of the Innocents. Home of the Innocents has been a part of the pilot project from its conception in July of 21. And we currently have 2 teams. Those teams consist of 2 therapists and a supervisor per team. We serve Jefferson County and Salt River Trail area. And as Julie mentioned, we are within that 90-minute radius. So some of those outer counties in the Salt River Trail region, we are barely touching. Our referral sources, we are not just limited to the Department of Community-Based Services. We also receive referrals from the Department of Juvenile Justice, Family and Criminal Court, other community partner agencies, schools. We also get parents and caregivers and insurance companies, as well as Louisville Metro Police Department. We have a strong relationship with staff there. We are projected to serve 66 youth and families annually with our current structure and our current staffing. And then our program strengths, we have stable leadership and staff with consistency within the program. You'll see that we do have struggles in connecting with additional people, but we have 2 therapists that started in our program in June of 2020, and they are still on the team. I've been with the program since its start, and our supervisor has been with the program for going on 3 years. So we have a lot of structure within the folks who have started with our program. We receive a lot of programmatic support from MST services, and we have strong stakeholder relationships and financial stability, through those existing contracts. And then we have our history of consistent positive outcomes and strong relationships with the other teams within the state. Our needs are streamlining referral processes to reduce wait times and keep our team at capacity. A lot of times we find ourselves chasing down referrals that end up not working out for various reasons. And so that slows our start times with those cases and ultimately reduces our capacity when we could be serving families more quickly. A challenge to attract those qualified MST clinicians. I won't go over all those reasons because they're very similar to my colleague that she mentioned. And then just better coordination and input with other systems on youth placements, whether that be the Department of Community-Based Services or Juvenile Justice. Sometimes we see that we're getting referrals too late in a behavioral cycle, and we're unable to make the impact that we know we could make early enough in the process. And so that's a struggle that we have. Thank you.
Good afternoon. Thank you for having us. My name is Megan Moore. I'm with KVC Kentucky, and I appreciate the opportunity to highlight the success of KVC's MST program and our MST team. We're the newest program. We started in August of 2022, so we've been going a little over a year. We have one MST team. It should be 4 therapists and 1 supervisor. We had a full team. We recently lost 2 therapists and then had 1 other therapist leave, but we have 3 therapists coming on board in November, actually next week. So we're grateful for that. We'll be fully staffed again. We serve the Southern Bluegrass region, so Fayette and the surrounding 9 counties. Currently, all of our MST referrals are received through DCBS, through the TWIST system, and we are capable of serving 60 families per year with a full team and a full number of referrals. I'm really excited to highlight some of the strengths of the program. I will start off by saying that we have really collaborative relationships with our key stakeholders. So our program and contract specialists at the state, our MST consultants, and the team that are here on this meeting. Our DCBS regional leadership, that's been key in implementing. And then with the Myers-Stauffer, who are the outcome evaluation team, we work closely with them. And then I will say I appreciate the collaborative relationship with the other 2 organizations that are implementing MST. That's been really helpful. I wanted to highlight a couple of the positive outcomes from our pilot since we started. We've had 40 cases that we've discharged, with 30 that have had the opportunity for the full course of treatment. The average cases per therapist have been over 5, so we've been at full capacity. One thing that I think is really great, so like Tom mentioned, MST monitors the adherence to the model, and our therapist adherence scores have been above the target of 0.61 at 0.774. So we're really proud of the fact that an independent measure has measured our therapist adherence to the model, and they're well above the target. Over 93% of the youth served have had no new arrests, and 86% are working or in school. Only 5% of the youth that have discharged have been due to lack of engagement. So with this population, that is really incredible. And then something that I think is really important is that 75% of youth with substance use as a treatment target show reduced substance use based on any measurement, and greater than 60% of those show reduced substance use based on an objective measure like a drug screen. So like the other organizations have mentioned, staffing, we're always looking at staffing. KVC has a really targeted focus on recruitment and retention of qualified staff members. So we work closely internally and then with our MST consultant to hire and retain qualified staff. And then to support our staff, because like they've mentioned, this is a challenging population. We want to support our staff in being here. Our supervisor has actually been here the entire time of our implementation. And then we have 1 therapist who's been here the whole time. So we're grateful for that. And then, one thing that's been a challenge is with the implementation of any new program, finding right referrals that are the right fit. So we've had about 36% of the referrals to our organization have not met the referral criteria. So we've been working closely within our leadership team and then with the stakeholders to say, how can we get from the get-go the right referrals so that we can serve the kids that need the service the most? Thank you.
Thank you. Thank all of you for that great overview. And when I first learned about this program, I've been very impressed from the very beginning. And I love hearing the great outcomes that this is having on our youth. This is a program for those of us who sat through the juvenile justice meetings last year in determining kind of the best path forward. This is the program that I kept referencing in terms of how we best treat kids who are justice involved or potentially justice involved and preventing all of that. Can you talk a little bit about exactly what happens when you get a referral? What sort of treatment kind of, I think this fabulous group of therapists descend really on the family and find out what they need. But can you kind of walk us through that and tell us why you think this is working? Anyone?
Yeah, Megan or Jennifer, do one of you all want to take that? Giving them the perspective, at the ground level of how you get referrals and what that looks like.
I'm happy to go. Our referrals come from DCBS. We have a great relationship with the DCBS gatekeeper. And so our DCBS team, they look at the kids that are coming into care or that have been in care that meet the qualifications for these services. And they contact our supervisor, and she reads the referral and says, okay, this kid looks like they meet the criteria. She might call the supervisor of that and talk through what's going on. And then she meets with our clinician, and they talk through it. And then that clinician is contacting that family and saying, hi, you've been referred for KVC services. But from the jump, it's really about aligning with families and saying, we're here to partner with you to do what we can to help. And I will say that the thing that I think is wonderful about the MST model is that it really depathologizes the child as the focus of the problem and says, what can we do to support you and your family, and take a look at what's going on in the child's life that is driving this behavior, and how can we attack what MST would call the drivers? What are the drivers? And so our clinician would contact the family, set up a meeting, go out and begin to do a really complete and thorough assessment of again, what are the drivers of this behavior, and how can we begin to develop and create a treatment plan that's going to address those drivers. But it begins with a really thorough assessment, and it's really aligned or driven by by family strengths, utilizing the MST assessment concepts. And then we also do evidence-based screening and assessment tools. So we use a YAZI. Jennifer, I don't know if you want to add anything to that, but what I will say is that it's a very collaborative process. So we're working in collaboration with the Department of Community-Based Services, the family, MST, to really wrap services around this child, to look at what's going on in this youth's life in all those different areas that Tom mentioned: peers, community, school, and really address those things that are driving that child's behavior. I don't know if that answers the question, but
yeah, I thought that was a fabulous answer, and I just wanted that sort of overview for some of our newer members who may not be familiar with MST. And I guess my next question is, and then if we have anyone who has a question or would like to weigh in, I welcome that, because I want everyone to kind of understand the strengths of this program and this model, and how it really addresses some of the big problems that we see in our youth right now. So how long is the pilot, and what is the reporting mechanism? What can we expect out of the pilot? I haven't seen, and maybe I've just missed it, but I haven't seen a report in the recent period.
I think the MST team can provide more detail, but I can tell you that the pilot program is set to run 3 years. So if my calculations are correct, we're entering our third year. And the team has hired MST and DCBS and Department of Medicaid have engaged a firm to do some very specific tracking. So when Gina mentioned the YAZI tool, that is a tool that is used to measure consistent progress among all the clients. And one of the strengths of the model that I really want to praise the MST folks for is that they have a very comprehensive process of monitoring not only fidelity to the program, but the results, and bringing providers together for quality improvement. It's ongoing. And so I think when you ask why is the program working, that's one of the primary reasons. But Tom, do you or one of your team want to speak more to the reports that will be available?
So I know we've been working, this is Tom Pikewicz again. just real quick background. So, and I think this works for all the teams, essentially are funded from two sources. To bill for their actual service, as was alluded to, there's a 3-year Medicaid pilot program. So that's how they bill for their direct services to the referral families. But they also, I think this is correct from DCBS, they also have running contracts, and those contracts pay them and to cover for those non-direct service related expenses with delivering the program, such as the licensing, but the quality assurance, the training, and those types of activities, and also for their own supervisors. So that's how it's funded. As far as I know, I'm not as directly in touch with that. I know Michelle Dean and I spoke to, I believe it was DCBS, and they have been engaged. I think it's with Chapin Hall on tracking. I don't know where the status of that is. I know we provided some structural information. I think, Michelle, that was about a year ago, or maybe maybe earlier in the beginning of this year.
Yeah, the other thing that I will just add at the provider level is that each team does what we call a PIR, which is a program implementation review report, every 6 months. And it lays out their commitment to required program practices, the outcome data, so the outcomes that we're getting for families, adherence, staffing, how many cases they've been serving, some of the data that the provider organizations just shared with you all. And those are completed every 6 months and are available that the provider agencies can disseminate to stakeholders as needed.
Okay,
and
thank
to
you.
follow up on that, Myers and Stauffer, who has been hired to kind of monitor the pilot, they compile the data from all 3 of our programs into an additional report. And we have meetings every 6 months to kind of review that data, see where we are, see what the state cost savings is for the programs combined collectively, so we can really see the impact across the state instead of in our individualized agency pockets.
Great.
Okay, yeah, I really look forward to seeing that data, and I appreciate your overview of the program. And Michelle, we didn't have you introduce yourself for the record, if you wouldn't mind doing that.
Sure, no problem. I'm Michelle Dean. I work for MST Services. I'm a director of the Team Support Services division of our organization, and that's the organization that these teams operate under. Thanks so much for having us today. This has been a great opportunity.
Well, thank you for being with us. And I don't want to cut anyone off. Is that pretty much it? And I don't know that we have any questions. I think you did such a good job that everyone fully understands the program. Questions? Okay. Well, thank you so much. I really appreciate all of your input and your work, certainly, on this important program. Thanks for being here. All right. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Okay, next we are going to hear about some treatment for neonatal abstinence syndrome. And we have some folks here from NASEND. And I will just invite you to make your way to the table and introduce yourselves for the record. And I think you're all in person, right? We don't have anyone online. Okay. All right. Well, thank you. Just let you go ahead and proceed when you're ready.
All right, well, good afternoon, and thank you, Chair Mosier, for that introduction, and also thank you and Chair Meredith, as well as the full committee, for allowing us the opportunity to present the work of NASEND today. I also want to add on another note that I'm very excited to hear about your bill, as it so very much aligns with our mission here with NASEND of healthy moms, healthy pregnancies, and healthy babies, all leading to better outcomes, and the focus in Kentucky is wonderful. I am Dr. Dawn Forbes. I am a local neonatologist, been practicing in Louisville, Kentucky for the past 15 years. Just recently retired in December so that I could focus more on Ascend. I continue to be a consultant for Behavioral Health Group, which is one of the largest addiction recovery and treatment centers in the U.S. I provide education, counseling, and opioid-assisted treatment for pregnant and early parenting women that have opioid use disorder. And important for today's conversation, I am the CEO and founder of Ascend. I'd like to tell you more about Ascend, but first I'd like to have my colleague introduce herself.
Yes, hi. Thank you for having us. Is this on?
Yes.
Thank you for having us. I do appreciate it. I'm Catherine North, VP of External Affairs for the Kentucky Association of Health Plans.
Okay. All right, so we're here to talk about Ascend. Ascend was founded by myself and several other neonatologists back in 2016 as our response to addressing what we were seeing as a significant increase in opioid-exposed infants. We had a tenfold increase and recognized that we had shortcomings in guidelines and protocols and therefore did not have the outcomes that we really would like to have just as day-to-day practicing neonatologists. We established Ascend so that we could help to improve and standardize the care and the outcomes for opioid-exposed infants. And fast forward to today, where Ascend provides technology-based clinical solutions and certification for healthcare systems and providers that truly does improve the outcomes for opioid-exposed infants. You guys, all of us, we are very well aware of the impact of the opioid crisis, especially here in Kentucky. We know that it has led to a significant impact in healthcare, and that's where Ascend is focused, specifically in pregnancy and newborns. Today, we know that 7% of pregnant women report that they are using opioids. That leads to an increase in fetal growth restriction and preterm delivery of the fetus. It also leads to impaired maternal bonding and long-term parenting issues. And very importantly, as Chair Mosier pointed out, it has led to significant increases in maternal, opioid-related maternal and mortality. As she stated, 54% of all pregnancies here in Kentucky, the maternal deaths are because of substance use disorder or related use of substance use. We also know that when moms use opiates during pregnancy, currently about 255,000 newborns are born each year exposed to opiates, and that has led to a 7 per 1,000 infants being born with NAS. That number is even higher in Kentucky. Our number is 19 per 1,000 infants born with NAS on average, and in parts of our state, specifically the area in the Appalachian area, that number goes all the way up to 77 newborns being born with NAS. We know that NAS is the withdrawal condition in newborns that affects feeding, sleeping, consolability short term. Long term, it affects development, behavior, and bonding with families. We also know that there is a significant lack, not just in Kentucky, but across the U.S., a lack in newborn assessment, care, and treatment, and that clinical gap has led to disparities in healthcare outcomes and variable outcomes across newborn nurseries, all the way up to level 4 NICUs. We also know that rolls up into a pretty high cost, about $1.5 billion each year for the care of infants with NAS, which is neonatal absence syndrome, or if you prefer, NOWS, which is neonatal opioid withdrawal syndrome. And that 80% of that cost is carried by Medicaid. Here in Kentucky, that number is 75%, so in line with the national averages. When we, as just practicing neonatologists, set out to address this problem, we knew that if we just focused on the newborn, that we were missing all the opportunities to truly change outcomes. And so we went upstream and we started working with obstetricians and recovery centers and community partners so that we could start improving pregnancy for healthier moms and healthier pregnancies, leading to hopefully healthier babies. We also recognized that if our work stopped in the newborn period, that we were missing that opportunity to carry those good outcomes long term down to at least the first 3 years of life. So we went downstream and we worked with community providers and pediatricians as well. What we ended up doing was putting together what we've come to know as our continuum of care, which is a standardized and comprehensive approach from pregnancy to pediatrics that truly does start to improve outcomes. We have implemented significant innovations, including technology-based innovations, which all were in place for us by 2013. And then fortunately in 2020, the American Academy of Pediatrics, with the NOWS statement, validated all the things that we had been doing for 7 years, with the exception of our assessment. And we hope that with the next AAP statement that we'll have recognition with that as well. Our platform is a technology-based platform, so we offer a certification which is expert-led and multidisciplinary, again, from pregnancy to pediatrics. It's wrapped in with other technology that truly allows us to be able to increase resources and increase access in some of the highest need areas, such as our rural areas, without the requirement of having to increase staffing or providers. It can all be done within the existing staffing, even in the smallest level 1 rural hospital that is out there. Our assessment is based on 6 symptoms, so it truly does a better job of replacing the current outdated standard. We've also integrated music as an advanced measure to help improve outcomes, because music improves feeding, sleeping, consolability, and long-term development. Nissin Learn is our online platform that stays in place even after the certification is complete, so that we continue to provide education on a day-to-day basis for current staff and new incoming staff. We know that the areas that probably need our help the most are the rural areas, and that is where we are focusing our resources as we start to put this out there. We know that by providing these resources, we can decrease the need to transfer infants to higher facilities. By not transferring, we can preserve the mother-baby relationship and also avert long-term loss of revenue from that birthing facility. Overall, it still decreases cost of care, but for level 1s and some level 2 hospitals, it can actually increase revenue by $500,000 for every 50 infants that are opiate exposed in their system. So far, we've provided training and education to 38 states with over 7,000 healthcare providers. We've impacted more than 1.6 million infants, and we have been able to certify 2 healthcare systems. When we look at our outcomes in this data, if you'll please read it from your right to your left, we've been able to significantly decrease the need to treat by almost 80%, decreasing from 43% to less than 10% of opioid-exposed infants with our system require an opiate-based medication. When infants do need treatment, and we absolutely believe that there are infants that need medication, that comfort and other interventions are highly effective, but it is not 100% comprehensive to date. So for those who need treatment, we've been able to decrease the length of treatment by 50%, decreasing from just under 16 days to 8 days, and we've been able to decrease the length of stay when we need to treat down to 12.8 days. Now that rolls up to a number that we can look at nationally, that right now the length of stay for all infants within our program, whether they're treated or not treated, is 4.9 days. This compares to the national average, which is 9.1 days, and it compares to Kentucky's average, which is currently 12.6 days, significantly worse than the national average. We also know this offers an overall cost reduction of about $12,000 per treated infant, and if you look at overall cost of care for NAS, it's a cost reduction of over $3 million for every 500 infants. Our approach is working with strategic partners, and that's really going to be very important as we move forward to really get this at a state and national level, offering our certification through associations, the Department of Public Health, managed care, and other hospital systems or large hospital systems, working with federal grants, opioid abatement funding nationally, and other legislative and state funding so that we can truly help these healthcare systems to be able to afford the implementation of this approach. It helps us to reach at both the pregnancy, the newborn, and the pediatric level. One partnership that we are incredibly proud of and very thankful that we have just entered into is with the Kentucky Association of Health Plans, and I'll turn it over to Catherine to tell you a little bit more.
Yes, we are. When we heard about Nissin and when I got to meet Dawn and hear about not only the resources and that standardization of care, but about the outcomes, about reducing the length of stay, about really a family-focused, infant-driven program, we were really excited to do this and leapt at the opportunity, especially for our rural communities. So we are proud to partner with Nissin. It will be a 3-year grant, $750,000, really focusing on those opioid-exposed infants in these rural areas where a lot of times resources are constrained because of where they live. And so the real game changer that we're looking forward to is that decrease of the need to transfer a newborn infant away from their mother, away from their caregiver, to an urban area. That we now get to bring these resources through Nissin to these rural rural areas, and we're encouraging mom to keep treatment or caregivers to do the programming that they need to do while also supporting the infant in various methods. So through training, through resources, through that standardization of care, all of this comes together to better the outcomes, which is, of course, what we're all aiming to do here. And we're really looking forward to this partnership where we will have these demonstrable results. So, the association, we really have focused some laser focus areas that we want to contribute to and invest in of how we can better our healthcare system in Kentucky and how we can address these inequities. And this partnership will do that. We will have key metrics that we will be able to see. And so this map, what you're seeing here, is a real pulse on where we are region by region across the Commonwealth when we're looking at infants born opioid exposed. As Dawn mentioned earlier, and you see there, the national average is 7 out of 1,000 babies that are born opioid exposed. Kentucky far exceeds that. But when you go into region by region, especially in that Appalachian area, you're seeing sometimes it's 11 times higher than the national average. In some areas, it's 77 per 1,000 babies. So time is quite literally of the essence. And so it's important that we get these resources in these healthcare systems, in these hospitals with these providers, and we are able to get boots on the ground and have a full holistic approach at supporting mother and baby as we're treating them in this, and to also better their relationship. So it will be a very impactful intervention on maternal, infant, and pediatric care. And so we look forward to it, and we thank you for the opportunity.
Well, I'm not really sure that I can say much more to follow that, but I do have one more slide. We do think that there's a great opportunity here in Kentucky. One of the things that we can do, we all know that the problem of opioid use and abuse and all the confounding problems, they started right here in our own home state, right here in the Appalachian area. We have the opportunity to continue to be number one, but for a positive reason, to kind of help define that national standard of care. If we take a look at our national numbers with 35% nationally needing to treat, but Kentucky being as high as 46%. Length of stay being at 9.1 days, but Kentucky's being at 12.6 days. And although Kentucky's doing a pretty good job when they have to treat, because their average is about 21 days compared to the national average being a little bit higher at 23, all of these numbers can be improved with the approach that we have and that we can share and that we can implement significantly. And it'll help us to kind of achieve that trifecta: better care, improved outcomes, and reduced costs, which is really what we all need to be striving for. At the end of the day, if we could do this in Kentucky, that turns out to be for Kentucky, because of reducing the overall days of care for all infants that are exposed, it's a $6 million cost of savings per every 500 infants, and that turns out to be quite a lot of money in savings. This ultimately benefits patients, health care, managed care, and the communities that we all live in. We appreciate the opportunity to speak today, and we'll happily take any questions.
Thank you so much for this presentation. I mean, this just warms my heart to know that a program like this is out there, and it makes so much sense, especially when we're talking about rural hospitals and that access to care. And we know what a huge problem this is in Kentucky. So we have one question from Senator Berg.
Thank you, Mrs. Chairwoman. Thank you guys for the presentation. I hate to be dumb, but I'm dumb here. This is a proprietary program that you are. Okay, first of all, what does it cost? Mm-hmm. Second of all, who utilizes it? Is this the physicians? Is this the nurses? Is this a healthcare system that utilizes it? And then what is it composed of? What are the component parts? And I'm sorry I don't understand this, but I really don't. No. So thank you.
No, absolutely. And thank you for the question, Senator Berg. Happy to answer. You are right. It is a proprietary program.
Is your microphone on?
Ooh, I'm sorry, I'm just turned away. Okay. You're right. A lot of the program is a proprietary program because it's based on a lot of different algorithms and data and research that we've done over the past decade. It comes together, and if I can go backwards, it comes together with all of these components that are here on the screen. The biggest one being our certification program. And what it is for hospitals become certified, because we go in and train their providers, which are physicians, nurses, nurse practitioners, but also lactation rehabilitation, physical therapy, occupational therapy, all of the individuals that provide care for this population is who we are going in and training and certifying, both with direct live training, with online on demand and easily accessible training, but also incorporating a good bit of technology that truly improves the assessment. Our assessment approach is real-time, responsive, and individualized. It's only based on 6 symptoms compared to the current standard of 23 symptoms, and with every time you make an assessment, you make a decision. So the current assessment, you make a decision every 24 to 48 hours, which means infants stay almost unnecessarily long on medication or have delays sometimes in starting medication, stopping medication, or even being ready to discharge home. What we do is real-time responsive because of the algorithm that's based in the technology. Because it is app-driven and nurse-driven, we don't need extra physicians or nurse practitioners or higher level of care. It can all be provided right at the bedside by the primary care provider for this population, which truly is nursing. Nursing are the ones, they're the ones that are at the bedside with these infants 24/7, taking care of the babies, taking care of the families. Physicians and nurse practitioners, we have our role. We come in and we make decisions daily, but then we're gone. So having a tool in the hand of the provider at the bedside has been really powerful in improving outcomes. Incorporating other technology with music and other feeding strategies, cuddle programs, and just basic comfort measures that a lot of people already do, but taking them sort of one step more to being a bit more advanced and integrating some things that not a lot of people do, like music and nutrition approaches, has been very effective. There is a cost, of course. I mean, anything that you do has a cost. We work really hard to keep our costs down, so the more that we can put this on a platform, the more that it can be accessible, then that helps us to decrease our cost. But it's about $150,000 for a system to implement our training and education, which includes full access to the technology for the first 2 years after the certification, and then an ongoing technology fee to continue to use the technology. That cost also includes continued, not just the certification as a one and done, but we are available throughout the certification duration, which is a 2-year certification, to answer questions, to implement new things, to be there as tech support, as well as everyday day-to-day guidance. And our goal is just to continue to move this more and more forward to a platform-driven process where live training, live interaction, telehealth all really becomes critical, both in the prenatal, the newborn, and the pediatric population. Does that answer a little better?
It starts to answer my questions.
Okay, I'm happy to. Is there a follow-up?
May I ask a follow-up?
Oh, sorry.
So this proprietary program has shown positive outcomes. And how many hospitals have you all trained? And what has been your best outcome, I guess, is my question. And then if this is just so standard, then why aren't we just teaching it to our nurses in medical school and school? And why are we having to pay somebody to do it, I guess, is my question.
Great questions. So a lot of this work was done as QI when we were private practicing neonatologists. So that was done and successfully done in 6 hospitals, all of those here in Kentucky. The full certification, which is where the company comes into play, and we've integrated technology and other resources that have taken it beyond our QI work, that's been implemented in 2 hospital systems. Both of those are in Indiana. And the outcomes that I shared with you were the 24-month outcomes of the first system. So think of it as our pilot, but that's our first systems implementation. Those outcomes were actually better than our QI work, which was done from 2010 to 2013. Okay. To answer your second part of your question as to why it's just not trained is because it's just not that simple. There is training and education. There's lots of education out there on comfort measures and other things, but what really makes us unique is the technology that we incorporate. Plus, it's the expert-led training. So, we have a team that goes in and assesses a hospital, determines, where they're doing things great and where they have room for improvement, and then we implement an approach through the certification to help them address their areas in prenatal and neonatal and in pediatric to truly start to improve their outcomes. It's not customized, but it is optimized for each system, and it's not just like it's not just, giving somebody a pamphlet to read. It's much more involved than that. I mean, there's hundreds of hours of research in the program to put it together. There's 6 years of development on the algorithms that we've put together. And yes, now it can be a turnkey program, but it still requires that implementation, that training, and that oversight in order to ensure it remains standard, so that you don't end up with a telephone game where one person tells somebody something and then they tell somebody and then they tell somebody, and eventually you have such variability. That's kind of what happened with our current just assessment. So the Finnegan assessment, if you take a look at that nationally, it's one assessment. It's on paper. It can easily be given to anybody, but at my last count, there are 23 different versions of it, because everybody tweaks it a little bit differently, modifies it here, modifies it there, and that's also one of the reasons why it's no longer considered to be an acceptable standard for the assessment of these infants, and why we're looking as a country, not just in Ascend, we are looking for a better opportunity for better outcomes through a better assessment and treatment approach. You're welcome.
Okay, thank you. And you touched on my question, which was about what the certification actually entails. So I think you kind of answered it there. And Catherine, as far as the Health Plan Association, I mean, you've invested $750,000, you said, for a 3-year as a 3-year grant.
Yes.
Who does that go to, and how do hospital systems apply to you for this grant?
That grant goes to Ascend, so that they're breaking it up. You could talk about how it's allocated more, but from our standpoint, that went to Ascend, and then that's broken down into the resources and the training models, and really to be able to match. So we're paying for some, and then others match in that.
That's correct. So we're getting $250,000 each year, and what we're doing is looking for Kentucky hospitals, preferably in rural areas, that are looking for this training. We're already in conversation with several. One of them is a 5-hospital system, so that would more than exceed our commitment for the first year. But we're hoping that at the end of the 3 years, with the $750,000, and with the expectation that hospitals will have some skin in the game too. I mean, it won't be a free giveaway because it's a lot of work, and when people have to put a lot of work into something, if they don't have a financial investment in it as well, it tends to not be as successful. But having a little bit of a financial stake ensures participation and cooperation and the support that the program needs. But we're hoping that we will have at least 8, but at the rate we're going, probably 10 to 12 hospitals that will be trained and certified by the end of this 3 years. Hopefully more, but with this funding specifically, and we're allocating all of that money to the training costs. We're not keeping any of that internally for anything other than to help offset the cost of training in these 8 to 10 hospitals. And if I may add one more thing about the certification, we are not self-certifiers or self-credentials. We are third-party certified through Annenberg Health Science Center, which is one of the major healthcare certifiers in the U.S., and they are out of California. So our program has been through their approval for certification, and they're the ones that provide the certificates and certification, as well as all the continuing education for physicians, nurses, dietitians, and therapists.
Okay, thank you. That really helps. Senator Meredith.
Thank you, Madam Chair. And just want to assure you that Senator Berg is a whole lot smarter than she gives herself credit for. But don't be so hard on yourself, Senator. Just a little bit confused by the numbers, because the question she asked you, you said that on your slide it says 10 Kentucky hospital healthcare systems have been certified. But then you said 6 hospitals have been certified. So do you have some that are kind of in process, or can you clarify that for me?
So with the grant, we plan to certify 10 hospitals. Okay. They have not been certified yet, but that is what we will allocate the money to. We have currently only certified 2 healthcare systems, and they're both in Indiana. We have trained lots of providers through non-certification, but other educational components of our training. But the full certification, which is what we will be applying this grant towards, it's been 2 healthcare systems. Prior to that, all of our QI work, we did that in 6 healthcare systems here in Kentucky, but that was not certification. That was QI work, which is the foundation of our certification.
So presently, just to be clear on this, no hospitals in Kentucky are presently certified.
That's correct.
All right.
That's
Thank
correct.
you. Well, aside from that, good presentation, very interesting. I appreciate it very much.
Thank you, and thank you for your questions.
Okay, thank you. And then Representative Raymer, do you have a question?
Thank you for the presentation. I just have a quick question when you're looking at your continuum of care on the safe discharge. So for those babies that have to have treatment. You know, we've got moms that are coming in then actively using. So is getting those moms into a rehab, is that part of that safe discharge, looking at options for them? I know Kentucky has some options where, you know, they try to keep moms and babies together. You know, and then I'm thinking about, you know, outcomes with moms that are using and breastfeeding, and I'm assuming that education piece is in there.
That's correct. So what we do is we train healthcare systems. We don't actually provide the services. We train the systems and help them with the pathways to do just that. A lot of the work with moms, though, is we try to focus it upstream in pregnancy, working with OBs and recovery centers and other community resources to ensure that moms have access and are able to at least be aware of the treatment options that are out there, the OB options that are out there, delivery hospitals that are available, and sort of guiding them to the resources that are there, working with the community so that they're getting a common message. You know, one of the things as neonatologists that we always had to struggle with is that often moms who have been seeing OBs, who've been in recovery during their pregnancy, had no idea or awareness that their infant might go through withdrawal because mom did all the right things. I mean, she entered into treatment, but she was taking an opiate-based medication, and unfortunately it doesn't matter whether it's prescribed or illicit, an opiate exposure can lead to withdrawal. So all of this information that was happening in the pregnancy was not preparing them for what was going to happen at the time of delivery. Certainly not for the baby and the potential of withdrawal and other complications, but even so for mom. You know, the fact that she was going to come in and be questioned by social work, that she might have DCBS or CPS involved, the fact that she may be drug screened, the fact that she may have this list of questions from everybody that contacts to her. The parents, the moms just weren't prepared for that. And so ultimately it all kind of came down to after mom had gone through, 8 to 9 months of pregnancy and been in the hospital for 2 to 3 days, and then suddenly at 4 a.m., because it's always 4 a.m. when a neo has to walk into a room, we're walking into the room telling the mom for the very first time that not only is her baby sick, but her baby has to be admitted to a NICU, that we're going to have to put the baby on an opiate-based medication. And back at that time, we were saying we're going to keep your baby for 4 to 6 weeks. So a lot of our focus in training other healthcare systems is directing it in that prenatal area to really make those resources available for mom, but equally as important, to work with those community resources for a consistent message of the right things to do, the options that they have, and what the impact of those options are going to be, included opioid-assisted treatment. We do work at safe discharge, and we train to make sure that there's good follow-up, so making sure that pediatricians know the routine, follow-up at 2, 4, and 6 weeks, not just for routine newborn things, but things that are specific to withdrawal, that parents have good education about what to watch for as far as continuing withdrawal symptoms or recurrent withdrawal after discharge, also to watch for things that are going to be developmentally related or nutritionally related, because those are ongoing long-term problems, and that's working with the hospitals to train them to work with their pediatricians and other community resources to really wrap around those families in a more structured discharge plan. But that's not what we do. We help them set up that program.
Okay, well, thank you so much. A lot of information, great presentation, thank you. I want to make sure that we have time for our last presentation, but I really want to thank you for being here. Thanks for the work.
Thank you very much. We appreciate the opportunity.
Of course. All right, next I'd like to invite Deputy Chief Justice, Supreme Court Justice Deborah Lambert, and Shauna Mitchell, who is the Project Director for the Kentucky Judicial Commission on Mental Health. And I just wanted to bring them to talk to us today to talk about the program that they're looking at in the intersection of the criminal justice and mental health, and how this is affecting the care that individuals are getting. And thank you so much for being with us. I'm proud to sit on the Judicial Commission on Mental Health, and I love the work that we're doing, and I just want everyone to have this update. So if you can just introduce yourselves for the record and go ahead when you're ready.
Let's see. Good afternoon, Chairman Meredith and Chairwoman Moser, and ladies and gentlemen of this committee. I'm Deborah Hembry Lambert. I am Deputy Chief Justice of the Kentucky Supreme Court, and here today in my role as Chair of the Kentucky Judicial Commission on Mental Health. And to my left is Shauna Mitchell. She is the project director and my boss over at the commission. She will be operating a brief, and maybe even a little briefer PDF kind of file for you, a PowerPoint for me today. And we know that each of you here today care about mental health of your fellow Kentuckians. I could certainly tell that by the presentations here today and the questions that were asked here today. It was very nice to be able to be in the audience and hear some of the exciting things that are going on in Kentucky. I would especially like to thank Chairwoman Moser for the invitation to present and her continued work on the commission, as well as Representatives Wilner and Burke and Senator Funke Fromeyer for their participation in the work groups. We have lots of work groups going on, and we'll try to briefly mention those. Of course, state courts have increasingly become the default mental health system in our state and in every state for addressing the needs of those with behavioral health issues. And certainly criminalization of behavioral health disorders has devastating effects on those individuals, their families, and society as a whole. And without access to services, the answer to mental health to the mental health crisis seems to fall to the justice system and to law enforcement. And this has broad-reaching and lasting implications and certainly cost. 4% of the general population experiences some sort of serious mental illness, but 17% of all inmates experience serious mental illness. And of that 17%, 72% of those inmates also have a substance use disorder. And certainly one would realize that incarceration negatively affects mental health outcomes, housing stability, employment, and their ability to integrate back into the community once they are released. But a well-planned state response can prevent justice system involvement, recidivism, and negative outcomes for many individuals who do have behavioral health issues. And these significant concerns, as well as recommendations from our national and state partners, led to the establishment of the Commission back in August of 2022. The Commission itself is charged with exploring, recommending, implementing, and implementing transformational changes to improve system-wide responses to justice-involved individuals who are experiencing three things: mental health issues, substance use, and or intellectual or developmental disabilities. There are currently 76 appointed members on the Judicial Commission, and these members certainly cast a wide net across the state, and they include judges, law enforcement, prosecutors, jailers, educators, private and nonprofit organization, hospital representatives, service providers, and faith-based organizations. We have representatives across the three branches of government, including agency representatives and legislative members. Senator Julie Rocky Adams, Representative David Meade, Representative Kimberly Moser, and Senator Whitney Westerfield are on the commission. And at its core, it truly is a collaborative effort, and we do seek to break through all these silos that have been built up over time to work more efficiently and effectively together. During our first meeting in September of 2022, the Commission established committees consisting of multidisciplinary stakeholders working together to solve these big systemic problems. And we tried to identify the linkages to services, enhanced court responses, and diversion opportunities. We are trying to minimize barriers that prevent individuals from receiving services, including knocking back stigma, transportation issues and limitations, and certainly housing is a part of every conversation nearly. Each committee met, elected a chair and vice chair, and established work groups. We have 3 committees. I'm going to go through this quickly to catch up on some time here. We have the Criminal Justice Committee, the Civil and Family Justice Committee, and Treatment and Access Committee. Each work group openly meets and discusses barriers and gaps, identifies potential solutions, and develop work plans. We have quarterly meetings of the commission as a whole, but the work groups meet on their own schedule and meet mostly by Zoom. You can see more clearly here how the commission is structured with established committees and how each work group falls under it, and this has been provided to each of you as a handout. We certainly had a busy first year. On May 31st through June the 2nd, we hosted a big mental health summit in Louisville. By big, I mean over 1,000 individuals attended that summit, and it was amazing. All 120 counties were represented, and that was very critical for us because we are trying to make a very grassroots type effort of having each county build their own strengths, know what their own services are in each community, and develop their own plans. So before they left the summit, each county met at a table and worked on that plan for the future. And we've been hearing back from them. Some of those counties have been meeting post-summit and telling us about some of those plans that are coming up. The agenda featured both national and state experts. The topics focused on 11 recommendations from the National Judicial Task Force, which is intended to examine the state court's responses to mental illness. And the feedback that we have received has been overwhelmingly positive. The attendees were asked to complete evaluations. One attendee said, I have learned to be less judgmental of the ones suffering with mental health issues. There are many factors that are out of a person's control, and I have gained compassion. After the summit, though, we still felt like something was missing, and what was missing was that consumer voice. So because of that, we figured out that the Kentucky Bar Association was holding their annual law updates in 9 locations throughout the state, and we could piggyback on those event locations and not spend any extra money. So we jumped on those towns, and we used those predetermined towns and had to use Wednesday night, the night before the Thursday meetings. But we've already had 6 of those meetings throughout the state. I have 3 more to go. They meet from 6 to 8 o'clock each night of those meetings. And it has been a powerful and humbling experience to hear directly from the individuals in our state who are struggling with an issue and struggling to treat that issue. There is nothing more humbling than to hear those very personal and intimate stories, and know that it is our responsibility to try to figure out a way to improve that so far as we can. So far, we've had over 600 people attend these town halls. We've heard from a mother whose son was released from an involuntary commitment, and she now has no idea where he is. We've heard from a woman who vividly remembers the trauma associated with being removed from her home as a child when her mother was arrested, and how that trauma has led to her own mental illness and her use of substances. And from an aunt whose nephew died by suicide just days after seeking help. The stories are very impactful and have highlighted to us some gaps in our services and our laws, quite frankly. The information we are learning from the town halls will be used to inform future trainings and shared with corresponding work groups to explore real solutions. And we certainly want to publicly thank all those individuals who have taken the time to stand up and tell us what has happened to them. I invite you to attend one of our remaining events. We are going to be in Louisville on Wednesday night, and Pikeville on November the 15th, and Bowling Green on November the 29th. Again, all the town halls are from 6 to 8 p.m. local time, and there's a more detailed flyer in your materials. We're going to have the commission's only going to have a couple of legislative recommendations, we believe. The work groups have identified some barriers and have been asked to explore potential legislative recommendations. Those have been reviewed, and many of those, quite frankly, did not require a legislative response, but were more of a policy or process clarification. So those can be done without the need for your intervention, but a couple of the barriers cannot be addressed outside of legislative change. And therefore, the Commission will be presenting its first legislative recommendations this session. The Commission's still working to finalize the specifics. We've heard concerns from the competency work group regarding the months-long wait list for KCPC evaluations to be done. That's at the Kentucky Correctional Psychiatric Center. KCPC is currently the only forensic psychiatric facility in Kentucky that can perform inpatient competency evaluations for felony offenders. Beds are limited, and the wait list is long and very complicated. We have learned that about 67% of offenders who were sent there by courts are found to be competent, but this ties up the beds that are limited anyway, and certainly that slows down the system. So the Commission's exploring changes similar to the model followed by Tennessee. And in Tennessee, licensed clinical professionals initially evaluate the defendants in the local jails, and if only then, if further evaluation and treatment is determined to be needed, a defendant is then referred on to their inpatient facility. This competency pre-screening would and should allow defendants to be evaluated more quickly while reducing the wait list for those who actually need KCPC services. Also, the Commission's Guardianship and Commitment Work Group has heard about patients who are suffering while waiting for someone to be identified to make decisions for them, and the current statute only allows for a guardian, individual with the power of attorney, a spouse or adult child, parent, or nearest living relative to act as a decision maker. And so the Commission's going to ask that a friend be able to be designated. I'm going to move on a little bit faster than I see that we're running out of time. We are going to be offering additional trainings. We're going to try to work on getting into those communities, if we can do so in an inexpensive way, with some day meetings that we have missed with our town halls. We have given you an email and web page for you to learn more about our commission. Again, we do meet quarterly. We invite any of you to attend in person at AOC or attend by Zoom. You're more than welcome. We are excited about the work the commission is doing, and if you have questions, I'll be happy to try to answer those.
Thank you so much for that great presentation, and I apologize for the lack of time. You do such a beautiful job in explaining all of this, and there is a lot going on. So I think that, this is just the first time that we'll hear from you all. Mm-hmm. I look forward to continuing our work and just hearing about more of the recommendations, and certainly as we dig into these subgroups, we're able to really identify some gaps and barriers. We have a few questions. Representative Rourke.
Thank you, Chair. Just very quickly, could you explain what the format of the town hall is for folks that haven't maybe attended yet, what they can expect? And then also, you might have already answered this with the need for pre-screenings, but what efforts are being taken to get mental health assessments and treatment sooner in folks' length of stay?
Answer the second part. I'll answer the first part, and then I'll ask Shauna to answer the second part. She's a little bit more familiar about the legislative part. With the town hall meetings, we go in and say, we're not coming here to tell you what the answers are to anything. We want to know what your problems are. So we begin with just introducing ourselves. We give some disclaimers about how we cannot guarantee that confidentiality can be maintained, and we give them ground rules about not being able to talk about particular cases. And then we open the floor up basically to the microphones, and we explain that we're collecting data. We don't want their personal identifiers. We also collect data anonymously through a survey from that, but that's what we do there. Shauna.
Thank you for such a wonderful question. We definitely looked a lot at competency and what that wait list looks like. I think it's important to point out that KCPC is not a treatment facility. It's only meant to answer the question of whether someone is or is not competent to stand trial. But what happens is when people enter that facility, oftentimes they do receive some type of treatment, which in turn ensures that they return back to the original location, sometimes better than when they came. So we have a pre-arrest and diversion work group that's looking specifically at whether or not those treatment aspects could be implemented on the front end actually while someone's in jail. And we do have some jails across Kentucky that have this wonderful model where that they have mental health professionals on staff that can do assessments, provide treatment and medication. That's a huge component, as well as access to medication while incarcerated. And some of those stabilization processes can actually happen in the jail prior to ever coming into KCPC.
Thank you so much.
Okay, thank you. And our last question is Representative Wilner.
Thank you, Madam Chair. Just a really quick comment and to thank you for your work, not just today's presentation, but the full scope of what you're doing with this commission. And I really especially wanted to thank you for bringing the voice of the consumer, the people who are struggling with these issues. It's so often missing from these conversations, not, across the board. But I think hearing those voices gives us a much needed sense of urgency to really address these issues. And I just can't thank you enough for including that. And I really want to thank you, Chairwoman Moser, for really an agenda that was amazing of real problems that real Kentuckians are facing every day and bringing us a really hopeful look at that solutions are on the horizon. So thank you, Madam Chair.
Yes. Thank you.
Thank you.
Well, thank you so much for being here. We did it all right in the nick of time and had a really full agenda. Thank you, everyone, for your indulgence of a few extra minutes. Our next meeting of the Interim Joint Committee here on Health Services will be on December 13th at 1 o'clock. And then we will allow everyone to have some time off for Christmas. Isn't that nice of us? So I see no further business, so we are adjourned. Thank you. It's great to hear you.
Yeah, I know. That's where I'm like, oh, is that just our viewer mail?
Oh, thank you.
I love that. I really, really do love that. I was like, yes.
Just saying it. Yeah.